All right, welcome everyone. My name is Kimberly Doris and I'm the Executive Director and CEO of the Graves Disease and Thyroid Foundation. Today's webinar is on the long-term use of anti-thyroid drugs, also referred to as ATDs, which has been a highly requested topic. Our program today was made possible with the grant from the County of San Diego's Community Enhancement Program. We're thrilled to have two experts with us today, Dr. Eve Bloomgarden and Dr. David Cooper. Dr. Bloomgarden will start us off with an overview of anti-thyroid drugs, and then Dr. Cooper will address long-term use of these medications, and we'll save time at the end for Q&A. We've already received a lot of questions, so if we don't get to your question today, please feel free to reach out to the GDATF. We'll provide our contact information at the end, and we'll work to get you an answer. This program is being recorded, and we'll have it available for viewing on our YouTube channel within the next few days. Our first presenter today is Dr. Eve Bloomgarden. She is a board-certified endocrinologist at Northwestern Memorial Hospital and an assistant professor in the Division of Endocrinology, Metabolism and Molecular Medicine at Northwestern University Feinberg School of Medicine. Dr. Bloomgarden's clinical expertise is in the management of patients with thyroid, pituitary, and metabolic bone disorders. This includes patients with autoimmune thyroid disorders like Graves disease, as well as thyroid disease in pregnancy, osteoporosis, and parathyroid problems. And with that, I'll turn it over to Dr. Bloomgarden.
All right. Hi, thanks so much for having me. Good morning. And it's been a very long year, so I'm excited to do something fun and non-COVID related. Coming to you from a very, very, very cold Chicago today. Okay. Hold on, technical. Okay. So we're going to go over a brief overview of the thyroid gland, definition of Graves, what to expect after your diagnosis in the initial few visits in the office. We're going to touch on the treatments, in particular anti-thyroid drugs, and then I will also do a brief talk about COVID-19 and autoimmune thyroid disease based on the questions that came in. I think we should touch on that as well. Okay, so the thyroid gland is a butterfly-shaped gland that sits right in the anterior neck, and it makes thyroid hormone. So thyroid hormones are secreted into your bloodstream and carried to cells and tissues in your body. They're involved in almost everything. So energy balance, temperature regulation, metabolism, heart function, muscle function, cognitive function, etc. And kind of given that long list of essential functions, it's important that the thyroid hormone levels are tightly regulated. And your body does this in the normal state via a feedback loop, which is similar to a thermostat. So what we see is a fine-tuned system where a signal comes from your pituitary gland, and which is right here. And that signal is called TSH. It binds to a TSH receptor on your thyroid gland, and that binding activates a pathway that tells your thyroid gland to start making thyroid hormones to secrete. These thyroid hormones, when they get to a normal level, typically will turn off the pituitary signal. So it's a feedback loop. So today we're not talking about normal, right? We're talking about too much thyroid hormone. And so what that looks like is when you have too much of circulating thyroid hormones, T4 and T3, we call that thyrotoxicosis or hyperthyroidism, increased thyroid hormone levels. And what we typically see here is the normal pathway works in that TSH turns off, so that your TSH is very low, but your thyroid hormone levels are very, very high. So the signal from your pituitary is off appropriately, but you still have too much thyroid hormone. So the pituitary sets the stage, and this is important so that we can talk about Graves disease. Okay. So then what's Graves disease? So I always show this slide every time I do a talk about Graves disease because I really think it's important to just remind people this is not going to your grave. This is Dr. Graves. He, in the 1800s, lent his name to this autoimmune thyroid disorder when he described, and I always just very, very clearly state that because people are often very worried about that. So what is Graves? So Graves disease is an autoimmune disease where there's too much thyroid hormone being produced and secreted by the thyroid gland, just like we just mentioned. It happens when your body makes antibodies to that TSH receptor. And those antibodies are inappropriately made because the immune system is designed to attack and generate antibodies to foreigners, not to things that are part of self. So that's kind of what autoimmune means. These antibodies, sometimes called TRAb or TSI or thyroid stimulating immunoglobulins, they stimulate the TSH receptor on the thyroid gland. So they do exactly what TSH, but the problem here is they don't turn off. So you can't have this loop where there's a signal, there's an action, and then the signal goes away because the antibodies are not being made by the pituitary gland. They're continuously being made by your immune system. And here's just kind of a fun little, drawing here. We have a trigger that activates the immune cells here, and that makes antibodies. And these antibodies are kind of like an ultimate trickster. So they look just like TSH. The thyroid doesn't really know the difference between TSH and TSH receptor antibodies. And so the thyroid's not doing anything wrong. It's just reacting to the signal. It's just the signal is the problem. So the thyroid just keeps working. So Graves' disease is very common. It is the most common cause of hyperthyroidism in the United States, and the prevalence is estimated about 1 to 1.5% of the population in general. You can see, it varies a little bit across the world, but certainly is not a rare disorder. And when you have too much thyroid hormone, it can cause a variety of symptoms. We have got a long list. Some people don't have any. So we'll kind of just walk through those. Some people will describe weight loss despite increased appetite, feeling really hot all the time, sweating, feeling restless, hyperactive, irritable. Sometimes we'll hear, spilling when they're drinking a cup of water, having trouble with handwriting using a pencil or a pen, insomnia. We'll hear menstrual disturbances or a history of infertility, shortness of breath, palpitations, sometimes more described as awareness of heartbeat. Muscle weakness as if they had just run a race but haven't done anything, fatigue. And then specifically in Graves, we may hear eye pain or excessive tearing of the eyes. Sometimes like there's a sand or a gritty feeling in your eyes or double vision. Now, again, you don't have to have any of these, but you may have some or all of these, and the symptoms can be very variable. But these are kind of a typical long list. And there are some precipitating or predisposing factors for who gets Graves' disease. We know there's a genetic susceptibility, so it does cluster in families. There's a gender predisposition for female gender. It's 4 to 5 to 1 compared to men. Smoking is a risk factor. We often will see new onset of Graves or of Graves after a major life event or stressful event. So postpartum, the death of a loved one, a big move at work, an infection, lots of different things. You don't have to have a pinpoint event, but we often will get that in history. High doses of iodine can trigger onset of Graves, more commonly in areas of iodine insufficiency. And then certain medications have been associated. So if you're coming to see me for Graves' disease, we will often, I'll just sit back and say, I'll take a look at you. I'll say, all right, tell me your story. I'm trying to confirm your diagnosis and figure out how hyperthyroid, you are. What do I think is going on clinically? We'll talk about family history. And I'm basically trying to determine the degree, the severity of symptoms, and also confirm the diagnosis. I'm going to examine you. I'm going to check and see, do you have an enlarged thyroid gland? I will probably do a thyroid ultrasound in the office as part of my exam especially to the diagnosis. It's often very obvious on ultrasound if somebody has Graves' disease. And then we're gonna send you for some lab tests for confirmation of the diagnosis. We're also either once I have the diagnosis confirmed, so it may be first or second visit, we're going to talk about three of the treatment options. There are 3 treatment options overall, and we're going to take into account different clinical, scenarios to figure out which treatment option is best for you. Always, we're going to write down the instructions for what we've discussed, and we're going to make a short-term follow-up appointment. And I just like this because I think it's fun, but we can skip it for time. Just Graves' disease can be very obvious on ultrasound. Okay, so there are 3 treatment options. We have medications, anti-thyroid drugs, we have radioactive iodine, and we have surgery. I like to think of these as medications are my first line go-to treatment option. They are more of a Band-Aid. They're not curing the underlying problem, but we are allowing your levels to cool off. You know, the goal is to kind of restore a euthyroid state and then allow your immune system to clear the antibodies, and so that you may go into remission. And ultimately, we're not committing you to long-term levothyroxine therapy. Radioactive iodine, I think of as more of a thyroid surgery without surgery, in that it gets rid of all of the thyroid cells, but it's slow, and sometimes you need a second dose. There are also risks to the new development or worsening of eye disease, and so that's a tailored approach. I really don't use a lot of radioactive for Graves, although certainly we do it. And then surgery is the fastest way to get rid of the problem. If you take out the thyroid, you get rid of the problem. Obviously, there's a lot of risk inherent to surgery, and you don't want to send everyone for surgery. It also, you know, it's the most definitive, but certainly has the most risk as well. And again, this is kind of another way to look at it. Surgery does depend on having access to high volume surgeons. Radioactive iodine is a nice targeted therapy, but increases the risk of eye disease and has some other issues with it. And anti-thyroid drugs are the mainstay of our treatment, methimazole and PTU. And Dr. Cooper is going to get into the long-term use of that. So how do we choose? We present the options, we talk about the risks and the benefits of each option. We talk about your goals, we talk about other comorbidities, we talk about whether you're planning for pregnancy, whether you have eye disease, what your timeline looks like, how sick you are, etc. The good news is there's no right answer. So truly, any of the 3, you know, people, we have a study, it's old now, but you know, showing that people were satisfied with the choice that they made. And we can always move from one group to another. So if we start with medications and ultimately you decide you want something more definitive, we can move. Obviously, you can't go backwards from surgery, but certainly you're not making a one-time decision. And the US is now kind of looking more like the rest of the world in that we use a lot more anti-thyroid drugs. It used to be that we were favoring radioactive iodine, but we're slowly but surely moving into the 21st century here. Okay. So methimazole and PTU interfere with thyroid hormone synthesis, not the release of preformed thyroid hormone. And again, what that means is that the thyroid, if it's big especially, can store a decent amount of thyroid hormone. So starting methimazole or PTU is not going to lead to immediate control of your thyroid levels, but it will certainly start to cool down the process, and you will block the production of new thyroid hormone. You can use them in preparation for a definitive therapy, or you can use them long-term. They may have a role in immune suppression, but again, they're not curing the problem. We're relying on your sophisticated immune system to do that. So methimazole. So this is what we're mostly talking about. PTU is really rarely used. In 2010, the FDA came out with recommendations to limit the use of PTU to a few clinical scenarios because of the risk of liver dysfunction. And so we use it in the first trimester of pregnancy if treatment's indicated. We sometimes use it in thyroid storm, and we will sometimes use it in the setting of a rash to methimazole. That's about it. So mostly when we say ATDs, we're talking methimazole or in the US. So methimazole, the starting dose depends on the severity of hyperthyroidism. So we're trying to give you the lowest dose needed to control your levels. And that dose will change over time as well. It's a once daily medication in the outpatient world, in particular. Again, it's not going to work overnight, but it does start to work within a few days. And then, slowly we get your thyroid levels down back to the normal range. So side effects, and everyone gets counseled about this when medications are started. I will say, about 10% of people, maybe less than that, will get some side effect or intolerance or notice, something different with medication. Typically it's a rash. And, some people will get itching, some people will get hives, a little bit of heartburn. But, what you see here is in black is methimazole and white is PTU. And the most common reported side effect with methimazole is rash, and this is about 6%. So not that common. With PTU, the most common was elevated liver enzymes. And these side effects are dose dependent. And so what the strategy typically will be to lower the dose. Sometimes we'll stop the medication for a few days and resume it with an antihistamine, like a, Zyrtec or Claritin, or, and see if we can get the medication back on board without side effects. But, if it's not tolerable, there are certain, a few circumstances where people just don't want to stay on it because of their side effects, and then switch gears, which is fine. And then major side effects with both of these is something called agranulocytosis. So again, it's rare. It's something we see in about 0.2 to 0.5% of all people treated, but it is life-threatening. And so part of starting one of these medications is counseling about this risk and what to do. So here is a copy of the methimazole rules that every one of my patients gets at every visit. We always put it on our instructions, and it gets printed out or sent through our patient portal. It essentially says you are taking PTU or methimazole for hyperthyroidism. It talks about, 1 out of every 500 people will get this agranulocytosis, which is an acute drop in your white blood cells. If that happens, you're at risk for a severe infection. And so what it says here is if you have a fever or a sore throat, please stop the medication, call my office, and go to the lab for a white blood cell check. And it always includes the phone number, and it's just a reminder. So every patient gets this every single time. So I just wanted to end on two important points that have come up, in the last few years that I think that we need to focus on. So needing to know. So I just wanted to throw in here about biotin. So biotin is a supplement that has gained popularity in the last year or two as advertised for hair and nail strength and support. It is now in almost every multivitamin, including prenatal vitamins. And the doses that are being advertised are much, much higher than the recommended daily allowance. And so the problem here is that our thyroid labs and many other labs are biotinylated, meaning we see factual interference in many of our labs. What this looks like is a low TSH, a high thyroid hormone level T4 or T3, and elevated thyroid antibodies. So one plea is we beg everyone to stop their multivitamins for at least 2 days before any thyroid blood tests. But on my end as an endocrinologist, when someone comes in with labs that look very abnormal, but they look completely fine and they don't have an enlarged thyroid, and I'm just skeptical of the diagnosis, we always ask about biotin. So at least 2 days, we say 2 to 7 days, stop all vitamins and before your labs. Okay. So I wanted to touch on COVID-19 as we're getting a lot of questions, and for good reason. We're in the middle of a pandemic. It's been a very long year. So a few things that we have learned over the last year, and the American Thyroid Association has put out a section that I have a link to here about frequently asked questions. But having autoimmune thyroid disease does not mean that you're immunocompromised. They're not one and the same. So, the immune system is very complicated. But as far as we know, we do not consider this to be an immunocompromised state. We have not seen an increase in adverse events from methimazole during the pandemic compared to the baseline. Graves disease does not increase your risk of severe COVID-19. So it is not an additional risk factor, but obviously there are other well-established ones, but Graves does not add to that. Certainly, if you have if you're critically ill from thyroid storm and you're in the ICU, that's a different story. But in and of itself, having Graves disease in the outpatient world does not change that. If you have a fever or sore throat and you're on methimazole, it's going to be very hard to know, is this COVID, is this methimazole and a granulocytosis? We follow the methimazole rules to make sure that your white blood cell count is okay. Recommend following the CDC guidelines for vaccination. There's no special circumstances and or no excessive risk factors or additions because of the autoimmune thyroid disease. We recommend certainly that everybody get vaccinated pending a contraindication that's from the CDC. And then just here for Graves' eye disease teprotumumab, we do not see, we haven't seen any evidence of an increased risk of severity of COVID-19 for people who are being treated with teprotumumab for thyroid eye disease. Okay. And here's just kind of a screenshot of what the American Thyroid Association FAQs looks like, and it's being updated. So feel free to look there as well. And then kind of just lastly, you know, as someone who in her spare time has started an advocacy group to share information and communicate with patients and colleagues across the country about COVID-19, we understand this is a time of flux, tons of information, tons of misinformation as well. And so it's important to go to good resources to get answers to your questions, like Graves Disease, Thyroid Foundation, like the American Thyroid Association. Try not to get bogged down in the Google world of thyroid and COVID-19, and communicate with your doctors with questions that you have. All right. Thank you.
All right. Thank you, Dr. Bloomgarden. That was excellent. And I'm glad you mentioned the tearing with thyroid eye disease. I don't know if everyone can see it, but I have one eye that's been tearing all morning long, kind of an illustration. We have some excellent resources on thyroid eye disease on our YouTube channel. We'll put that contact information up at the end. So I highly recommend some of those videos. So next we'll hear from Dr. David Cooper. Dr. Cooper is currently Professor of Medicine at the Johns Hopkins University School of Medicine and Professor of International Health at the Bloomberg Johns Hopkins School of Public Health. He serves as an editor-in-chief for endocrinology for Up to Date, as a contributing editor of the Journal of the American Medical Association, and as the deputy editor of the Journal of Clinical Endocrinology and Metabolism. He is the chair of the Subspecialty Board for Endocrinology, Diabetes, and Metabolism of the American Board of Internal Medicine. Dr. Cooper is the past president of the American Thyroid Association and a recipient of the American Thyroid Association Distinguished Service Award. And with that, I'll turn it over to Dr. Cooper.
Thank you very much for that nice introduction. And I'm really happy to be able to speak to you this morning about something that many patients are interested in, long-term anti-thyroid drug therapy. I'm going to first talk a little bit about the treatments for Graves' disease, their history. Dr. Bloomgarden went over this, of course, just a few minutes ago, but more of the historical perspective. Then talk a little bit about anti-thyroid drug development and use, and then really focus on the concept of remissions after taking these drugs, the importance of monitoring these antibodies that Dr. Bloomgarden talked about, the antibodies that cause Graves' disease, talk about factors that predict whether a person's going to have a remission or not. And then what about people who are not in remission? Should they just continue to take the medicine, or should they move on to some definitive treatment like radioiodine or surgery? And then I'll just finish up talking about, again, using long-term anti-thyroid drugs in practice. I just want to start out by using this quote from 1889. Graves described Graves' disease in the 1840s. So it was a known condition at the end of the 19th century. Surgery was the only treatment. But this is an article by a surgeon who wrote about the remarkable features of Graves' disease is its spontaneous tendency to recovery. And then once that happens, the patient's freedom from all risk of relapse. And he went on to say that many people with Graves' disease pass on to the most extreme condition of debility. They could even die. But then if they don't die, some of them turn a corner and then never look back. So this idea that it can just go away without any treatment at all was well known even more than 100 years ago. So in terms of the different treatments, surgery, as I said, has been used for a long time. It was very, very dangerous back at the end of the 19th century, but the use of iodine to prepare people made it safer. In the 1940s, they discovered that radioactive iodine would be taken up by the thyroid and could be used for treating, and this was first done at Mass General. And then in the 1920s, it was noticed that there are certain foods, cabbage, turnips, other things cause enlarged thyroids in animals, and then people began to explore, well, what chemical was doing that in the cabbage, and that led to the development of compounds that would have a negative effect on thyroid function. And Astwood was the original person back in the 40s to discover and describe many of these compounds that ultimately are now used to treat Graves' disease. This is Dr. Astwood, this is the original paper from 1943 in the Journal of the American Medical Association called Treatment of Hyperthyroidism with Thiourea and Thiouracil. So these were the two original compounds that he used. And of course, nowadays we have methimazole and propylthiouracil. I'm just showing these are the structures, but I know you're not interested in the chemistry of these, but I just want to show you these are very, very simple molecules. And you know, the other point is that these medicines, unlike the medicines we use today to treat high blood pressure or diabetes or virtually every other disease, we don't use medicines to treat those diseases that were developed in the 1940s. So these are old treatments, and there's really nothing new on the horizon, although at the end of my talk, I'll say some things that maybe in the future there will be other treatments. But here's methimazole, as Dr. Bloomgarden said, that's the one we use. It's also called Tapazole, that's just the brand name. And so Dr. Astwood started treating people with anti-thyroid drugs. The ones he was using was Thiouracil and propylthiouracil. And on this graph, we're looking now at people who took the medicine for a year or two and then stopped the medicine. And we're looking at the number of people who remained healthy years later. So on the bottom of the graph, you see it goes down to 4 years, 48 months. And on the side here, we see the number of people who are still in remission. And you can see that at the end of 4 years, more than half the people were still in remission. So after a course of medicine, people could stay normal. And this is one of the first descriptions of this phenomenon. And then from the same group, again, Astwood in 1966 looked at 176 people who had taken the medicine and followed for 6 years. And again, more than half the people were fine even years later. And of the people that relapsed, that is, became hyperthyroid again, most of the time it occurred in the first year or two of stopping the medicine. And if they remained normal, they tended to stay pretty normal after that. And so this concept of remission was actually first described by Astwood. Although, as I said, even 100 years ago, it was observed that people could spontaneously go into remission. But Astwood's the one who described it after a course of anti-thyroid medication. And this led to this concept. This is just a lecture that was given to the American Medical Association by John Eager Howard, who was the director of the endocrine division at Hopkins, who said, the approach to the therapy of thyrotoxicosis, he was talking about Graves' disease, is to control the disease for a lifetime, if need be, with a drug such as PTU or propylthiouracil, which is the drug that was being used mostly in the 1960s, until spontaneous remission occurs. So this is not a new idea that we're talking about today. This has been something that's been around for decades and decades and decades. So what is a remission? A remission is defined as having a normal thyroid for a year after the drug has been stopped. So if you take methimazole, let's say, and then you stop it, and then 4 months later it comes back again, that's not having been in a remission. You have to be normal for a year, and that's called being in remission. So here's a patient with Graves' disease, a typical young woman. You can see her enlarged thyroid. She has mild thyroid eye disease. And so she presents for evaluation to Dr. Bloomgarden or me, and these are her thyroid function tests. We won't go into those, but they're elevated. And then I want to just focus on this thyroid stimulating antibody level, TRAb, or TSH receptor antibody, which Dr. Bloomgarden talked about, and hers is elevated. So the question is, what is the best treatment for her? These are the different treatments that Dr. Bloomgarden talked about. And again, I'll just focus on the fact that all of these have been used, for almost 100 years or more. And she pointed out the advantages of the anti-thyroid drugs, which are that they don't kill your thyroid or get rid of it. They don't cause hypothyroidism, but they're not definitive. That is to say, they don't cure you. They can have side effects, which he talked about. Also, when you're on this medicine, you need to go to the doctor and have blood tests and that sort of thing. So one of the things that people used to talk about, and that's why I call this the traditional paradigm, is that in people, this has been known for decades, if you have more severe Graves' disease, so bigger thyroid, more abnormal thyroid function tests, high level of the anti-TSH receptor antibody, a history of relapses after you stop, then people would say, oh, well, you're not a good candidate for anti-thyroid drugs because, you know, we just know that this is the kind of person that's not going to go into remission. And it would be better for you to take radioactive iodine or have surgery. This would be except in people with eye disease who also don't have a high chance of remission, but radioiodine would not be used in those patients, of course. Now, Dr. Bloomgarden talked about this study, and I'll just tell you a little bit more about it. So this was just a survey of endocrinologists published in 2012, presenting or given a typical patient like the one I just told you about. And we were asked, well, what would be the best treatment for her? And you can see here in red is radioiodine, and in blue is antithyroid drug therapy, and green is surgery. And you can see here that all over the world, blue predominates, antithyroid drugs. And yet in the United States, for some reason, doctors prefer radioactive iodine. This is, again, not so long ago. And the interesting thing is that if you then look at what doctors actually did, not what they said they would do, but what they do. So this is based on insurance claims data of what patients actually got for their treatment. You can see, although radioiodine and antithyroid drugs were, you know, interchangeable in terms of the frequency with which they were used, ever since, you know, the early 2000s, radioiodine has taken a nosedive, and antithyroid drugs are now clearly the predominant treatment for Graves' disease. And I think this is driven by patients, not by doctors. And you can see here what doctors said they would do is give radioiodine to most people, at least in the United States. But that's not what is happening. Okay, so getting back to our patient, she says she'd feel most comfortable with a course of methimazole therapy. So here, you know, is the concept of letting the patient decide. The patient's input is really important. We don't just dictate to the patient what they ought to do. She doesn't want surgery. She's not enthusiastic about radioactive iodine because she has mild thyroid eye disease. And she's hopeful that maybe she'll be one of those lucky people that will have a remission. And so again, this is just driven, I think, mostly by patients now, although I think a lot of doctors now prefer antithyroid drugs as well, like Dr. Bloomgarden was saying. Okay, so the American Thyroid Association has guidelines and recommendations, and what they say here is in a person like this, who chooses antithyroid drug therapy, the medicine should be given for 12 to 18 months and then stopped if thyroid function and these antibody levels are normal. So this is the concept now of starting the medicine, monitoring the thyroid test, and also checking the antibodies. And if the antibodies go away, which they may, you could try stopping the medicine. So this is the traditional thing that we do. And I just want to get back to this idea of these anti-TSH receptor antibodies just to emphasize a couple of things. So here is just the normal situation that Dr. Bloomgarden told you about. The pituitary makes TSH, it binds to receptors on the surface of the thyroid cells, and thyroid hormone is then made. And in Graves' disease, you have B cells which produce antibodies, which then bind to the same receptor as TSH and mimic the effect of TSH to produce excessive amounts of thyroid hormone. So it's these antibodies that are the direct cause of the hyperthyroidism. Now, it turns out that these antibodies, you can measure them after a person gets treated with the different treatments. And lo and behold, it turns out that they actually go up after a person gets radioactive iodine. This may even be the cause of the worsening of the eye disease that we see. And after surgery and antithyroid drug therapy, they go down. They go away in many cases. So this is a really important thing, and it may be the reason that some people do have remissions after a course of medicine because the antibodies tend to go away. But this is an oversimplification. And in the real world, here is what happens to patients after methimazole therapy for 18 months. Antibody levels shown here go down, but some people, they go away and they're below normal. So normal, or the lower limit of normal, is this red line here. And some people, they go down, but they don't go away. So, and you can see here in the ones where it goes away, 70% of people stay normals, 30% relapse. But if the antibodies are still positive and you stop the methimazole, it's just going to come back again. So yes, it does go down in almost everybody, but they may not go down to normal. And so this is this idea that people are different. And some people, just the antibodies go away and they just are fine and that's the end of it. But in other people, they sort of cycle. And so they go away, you stop the drug, the disease comes back, you give them the drug again, they go into remission, it comes back, that kind of thing. Although you can see there's a trend to going down. And then in some people, they just the antibodies just never go away. So here's this table that I showed you before about, disease factors and the chances of remission. And another thing that we could even look then is whether the dose of the medicine makes any difference or whether the duration of the therapy makes any difference. And it turns out, and this is the basis of this long-term therapy, that the longer you give it, there is evidence that the higher the chance of the patient ultimately having a remission. So the question is, how long? And so back in the 1990s, there were randomized trials where people were given methimazole for different periods of time in these different studies, 6 or 18 months, 12 or 24 months, 6 or 12, 18, 42. And you can see there's really not a lot of difference here. There was a difference between 6 months and 18 months in this study, but for all the other studies, it didn't seem to matter all that much. And this is where this idea of giving it for 12, 18 months, something like that, and then stopping the medicine if the antibodies go away, because it doesn't seem to matter if you take it any longer than that. This was this idea, which is now probably been shown not to be true, because these studies didn't give the drug long enough. So, but this is where this ATA guideline comes from. Take the drug for 12 to 18 months and check the TSH and antibody levels. But in this recent study by Dr. Azizi, who is one of the world's experts on this from Iran, he took 258 patients who had been on methimazole for 18 months and then randomized them to either stop the medicine or continue it for another 5 to 10 years. And then he looked to see what happened. And of the ones who stopped it after 18 months, about half relapsed and half didn't. But in the ones who took it for 5 to 10 years, most of them, when they stopped it, remained normal. And here's just a slide from that study showing the relapse rates. These are the people that stopped it after 18 months, followed for 4 years. Half of them relapsed, but in the people that took it for 5 to 10 years and then stopped it, only about 15% had a relapse. So here's the previous slide. Now we're sticking this on here. You can see on this last study that if you take it for years, there's only a 15% chance, at least in this one study, of a relapse. So part of the ATA guideline is to measure these antibodies prior to stopping the medicine because it predicts who can stop it and who can't stop it. So we always do that. And as I said, you can see that there are some people where it has gone away and other people where it hasn't. And if it hasn't gone away, you're not going to stop the medicine because most people will just come back. It'll just relapse very quickly, actually. So the guidelines say if a patient becomes hyperthyroid after you stop the methimazole or these antibodies become positive after a course of methimazole, consideration should be given to treatment with radioactive iodine or a thyroidectomy. But they admit that in some people, it wouldn't be so wrong just to continue to take methimazole. And so here is the algorithm that we use. You diagnose Graves' disease, you take the methimazole for 12 to 24 months, you measure the antibodies, and if they're still there, then you continue the medicine, or you say, okay, look, we gave you a chance, it didn't work, now you've got to move on to radioactive iodine or surgery. Or if the antibodies are gone, you would stop the methimazole, but then the person could relapse, and then you go, again, should you go back on methimazole, or should you move on to radioiodine? And so the question is, which option, after you stop the methimazole, and then it comes back again, is better? And so, you come to, there's a fork in the road here. Should you say, I've given up, I'll just take radioactive iodine, or should you say, I want to go back on methimazole or stay on methimazole? So in this study, this is not a randomized study, but a study of 230 people, 238 people who took methimazole and then relapsed after a couple of years of treatment. And then 124 people decided for whatever reason they were tired of methimazole and they took radioactive iodine. 114 went back on methimazole. And then they followed these people for 6 to 7 years. And what they found was that in the people that took methimazole, more of them were euthyroid. That is to say, more of them had normal thyroid function on methimazole than the people that took radioactive iodine and became hypothyroid and then were on levothyroxine therapy. That is to say, surprisingly, it was better to be on methimazole and you had a higher chance of being normal than if you took the radioactive iodine and became hypothyroid. Also, the body weight was higher in people that were who took radioiodine and were on levothyroxine compared to people that were on methimazole. And finally, in those people who had eye disease, either at the time or afterwards, it actually got worse in people that had taken radioiodine versus people that were on methimazole. So the HEA recommends you could consider radioiodine or surgery, but staying on methimazole is also a reasonable thing to do. And some patients say, well, gee, can I just stay on this indefinitely? Aren't there these side effects? And as Dr. Bloomgarden said, there are allergic reactions that we are very worried about, but they almost inevitably occur in the first few months of taking the drug because they're allergic reactions. There are no long-term side effects of taking methimazole after decades of taking it. So here is, the traditional approach. You get Graves' disease, you take methimazole, you measure the antibodies. If they're still there, you stay on the methimazole or you move on to radioiodine or surgery. If the antibodies go away, you'd stop the methimazole. If you relapse, then you could go back on methimazole or take radioiodine or have surgery. And what I'm saying is that in a new way of thinking about this, if you're diagnosed with Graves' disease, you take the drug. If they're still there, you just stay on the methimazole. You don't move on because the treatment has failed. Or if it stops and you relapse, you just go back on methimazole. You don't move on. And that's what I'm talking about now, that this is kind of more popular with many of the patients than doing something more definitive. And then I just want to finish up with this study that was just published just a month or two ago, again from this Dr. Azizi in Iran. He had 59 patients with Graves' disease who took methimazole for 14 years. And at that point, 32 of them decided just to stop, and 27 said, okay, I'll just continue it. And then they were followed for another 10 years, 6 years. And then of the 32 people who had taken methimazole for 14 years, 6 of them actually did relapse. Of the 27 who just continued to take it, they just took it for another 10 years and they stayed normal. The mean dose of methimazole to keep these people normal was 2.5 milligrams a day, so just a tiny, tiny dose. And again, just to emphasize, no one had any kind of adverse reaction after taking it for 24 years. And this is just the slide looking at first in the orange, the mean dose of methimazole. So it started out being about 10 milligrams a day. And then after 12, 14, 24 years, people were on about 2.5 milligrams a day. This is the TSH level, so they were just normal for all that period of time. The antibody levels were very high, so normal is less than 1.75. So at the beginning, just like everybody with Graves' disease, the antibodies were very high, 14, but then they just were normal, but they didn't stop the drug, even though the antibodies were normal. They just left people on the drug, and that led to this relatively high remission rate. This is the remission rate here of the people that stopped. So after 14 years of treatment, 80% of people remain normal after stopping the drug, not 50%, 80%. And so here's this idea then of all these different bad things that mean a lower chance of remission. And I'm just saying, forget it. It doesn't matter. You can go on methimazole and just stay on methimazole. And so again, this gets back to this idea of Dr. Howard, who said you could take it for a lifetime if need be until there's a remission. That's the idea here of this, long-term therapy. Again, we're kind of reinventing the wheel here. Oh boy, what about that? No, this guy said this in the 1960s, and Astwood said it in the 1950s. So a summary: methimazole therapy leads to long-lasting remissions in 50% or more, but the remission rates do increase with the duration of treatment. And even if there's a relapse, you can go back on methimazole, and that may lead to people doing better than opting for radioiodine and levothyroxine in terms of thyroid function, weight, eye issues. So one approach is just to take the drug for 5 to 10 years. Don't even bother checking the antibodies, just take it. And this is similar to many other chronic diseases, that we treat, high blood pressure and high cholesterol and that sort of thing. Now, so who should be considered for this? Anybody with mild disease on low dose therapy who has relapsed in the past. There's no reason they can't continue it. I think it's certainly reasonable for children rather than destroying their thyroid. People have eye disease, you're not going to give them radioiodine, obviously. And anybody who wants to avoid removing their thyroid, who's stable and doing well on methimazole. Now, there are some treatments that are around the corner that actually get at the cause of the Graves disease. And I just mentioned the idea that there are drugs that can block the receptor so the antibodies can't stimulate the receptor. These could be antibodies to the receptor that are smaller, and there could be small molecules like any drug that can block the receptor. So the idea here, here's that cartoon I showed you before. Here are the antibodies stimulating the receptor. And you can think of a drug that just binds to the receptor and blocks the antibodies from stimulating the receptor. That would be, the ideal treatment, but we don't have that yet. So this is what I went over, and I'm sorry if I went over time a couple of minutes, and I thank you very much for your attention.
All right. Thank you, Dr. Cooper. That was excellent. And I'm glad you mentioned the ATA guidelines. That's really an excellent document. And one of the things that I think is important with that guidance is, for physicians to talk to their patients and find out, what are their values and preferences and priorities, and which of the 3 available treatment options is going to be best for them. Whereas when I got diagnosed, so I actually did use anti-thyroid drugs long term and eventually went hypo. I was one of those low frequency cases. But at the time I got diagnosed, a lot of other people at that time were just going straight to RAI. And so I think, that ATA guidance is really valuable in terms of stressing the importance of patient preference. So we do have time for some questions. So we'll start off with the question for Dr. Bloomgarden, and this, recognizing that this could be an entire webinar in itself. So maybe you can touch on it briefly. Is methimazole safe during pregnancy?
So no, this is a great question, and it is absolutely an entire other talk. The short answer is no, at least in the first trimester. So there's a risk of embryopathy, which can be very serious and debilitating. We actually do not use methimazole in the first trimester of pregnancy up through at least 16 weeks. Oftentimes, as you go through pregnancy, the need for medication or treatment actually it reduces, such that we can often get patients, even if they needed treatment, off of medications by the end. But it's really that very early pregnancy where there's an absolute contraindication.
Okay, thank
you.
So
I tell my patients, if we talk a lot about reproductive planning ahead of time is the ideal way to do it.
Okay, excellent. And for Dr. Cooper, so you put together kind of that flow chart of options. What are some of the factors that might influence a patient to get off the train of using anti-thyroid drugs and to pursue definitive therapy?
Well, that's a good question. And some people do get off the train because they're just tired of seeing the doctor and having blood tests. And it's not that they feel bad on the medicine. It's just that if we try stopping the medicine and it comes back again, and they have to go back on the medicine, for some people, it's just easier to have a definitive treatment, getting rid of their thyroid, either with radioactive iodine or surgery, being on levothyroxine, and this never looking back and having to worry about their thyroid again. For most people, these treatments, surgery and radioiodine, even though we say, oh, well, they could make your eyes worse, or they make you hypothyroid. I mean, most people do fine. I've had radioactive iodine for Graves disease, and I'm doing fine, So for some people, that's what they feel most comfortable doing. Not usually right off the bat, but as you say, jumping off the train after a while, they just get tired of it. And I'll just say one other thing. that I don't think Dr. Bloomgarden talked about. If you stop methimazole, let's say, and then a year later you relapse and you go back on methimazole because that's your choice, you still can get an allergic reaction, even though you didn't have an allergic reaction the first time you took it. So it's almost as if you've never taken it before. And you can't have any of these rashes and itching and even the bad things like granulocytosis after going back on it after a prolonged period of being off of it.
Okay, thank you. So that 90-day period restarts if you have a stop and a restart of the medication. So for Dr. Bloomgarden, is there any role for methimazole when your thyroid hormone levels are stable without meds, but your antibodies are still elevated?
So I typically will not treat you if you have normal thyroid levels. Again, the medications block the production of excess thyroid hormone. And so, you know, they're not going to help. In fact, they will make you hypothyroid.
Okay, thank you. And for Dr. Cooper, and I actually did not ask this question, submit this question, it was someone else. What percentage of patients eventually turn hypothyroid after long-term use of anti-thyroid drugs, and do we know why this happens?
Well, so this is a phenomenon that was recognized in the 1970s and 80s, that people somehow occasionally become hypothyroid after a course of anti-thyroid drugs, and the disease just sort of burns itself out and the person then becomes hypothyroid. You say what percentage? It's not really known. It's not that common. Maybe 20%, 15%, something like that. The vast majority of people after a course of anti-thyroid drugs stay normal if they're in remission and do not become hypothyroid. Why this happens is probably just part of the same autoimmune process that's going on, where there are not only antibodies that stimulate the thyroid, but other antibodies that can cause inflammation in the thyroid, infiltration of the thyroid with immune cells that can cause the thyroid not to function properly. But I know that happened to you. It's not that common, but it certainly does happen. And that's why I think patients with Graves' disease who took anti-thyroid drugs, who then go into remission, need to be monitored with thyroid function forever, because they could develop recurrent hyperthyroidism, even though it would be rare, or they could become hypothyroid.
Okay, thank you. For Dr. Bloomgarden, is there anything specific I can do to lower my antibodies? And I think I know the question to the answer to this, but I'll throw it out to you anyway.
So, don't smoke, and I would say that's about it. It's just tincture of time and we'll treat you if you're hyperthyroid. But there's nothing that you have to do. I mean, in some ways the answer is a relief, right? There's no responsibility in terms of there's no supplements, there's no special diets. You don't need to live a stress-free life, which is an impossible task anyway, and so I usually try and take the burden off of the individual. Like the antibodies hopefully will come down over time, but there's nothing extra aside from avoiding cigarette smoking, which we know is a risk factor for worsening.
Can I just chime in about that?
Yeah.
So, but this questioner gets at the issue of the antibodies being the cause of the problem. And unlike other autoimmune disease like Crohn's disease, or rheumatoid arthritis, or psoriasis, or all those things you see advertised on TV, where there are drugs that actually help the person get rid of the cause of the problem, we don't have that in Graves' disease. But I predict that we are going to have something like this, who knows when. I don't know when. At the end of my talk, I mentioned the idea that people are developing drugs that can block the TSH receptor so the antibodies don't stimulate it, or even immunosuppressive drugs, like the drugs that are used to treat rheumatoid arthritis. Now, we don't use those now because they have side effects, and having Graves' disease isn't so bad, so we're not willing to risk side effects. Whereas, if you have rheumatoid arthritis or Crohn's disease, you're willing to risk those side effects. So those are much worse diseases, generally speaking. But at some point, they're going to develop a drug that will get at the root cause of Graves' disease. And I predict that it's going to be within, well, Dr. Bloomgarden's lifetime.
All right, thank you. So for Dr. Cooper, can anti-thyroid drugs become less effective over time? Or I think maybe the question is asking, can your body become resistant to the effect of the anti-thyroid drugs?
No, that doesn't happen. In fact, as you saw from that last study I showed you, people become more sensitive to it. I mean, at the end of this 20-year period, people were well controlled on 2.5 milligrams a day. And I even have patients who've been on it for a while are on half a pill, 2.5 milligrams, 3 days a week. And they're doing fine. So no, you don't become resistant to them.
Okay, very good. And this is one of the toughest questions that we get, which is, my levels are normal, but I still have symptoms. What do I do next? Dr. Bloomgarden, I'll throw that one out to you first.
So no, it's a great question. Of course, this comes up all the time. And I think there's two possibilities. One, is that your symptoms are related to the thyroid. And we do know there's a quality of life impact of having Graves disease or autoimmune thyroid disease that is very hard to pinpoint, but exists. But I typically will say, that we should investigate for other reasons why you're not feeling well. Wellness is a very difficult kind of, topic to address, in a short answer, but, we look at sleep, we look at diet, we look at exercise, we look at mood, make sure, that you're truly your thyroid and not, that we're not kind of skirting the edges. But, I think just empathy goes a long way. Like, we know that, that people still struggle with this. I don't have a perfect answer, except, we just be open to looking for other things.
Okay. Thank you. And we've got time for one last question. So Dr. Cooper, most of the studies that you mentioned were on methimazole. Are there concerns over safety profile long-term with PTU and specifically perhaps with vasculitis as a concern the longer you take that drug?
So most of the side effects that occur with antithyroid drugs, like rashes and itching and agranulocytosis and liver problems, as I said, and Dr. Bloomgarden said, occur early rather than late. There is this quite rare side effect of vasculitis, which is a really serious allergic reaction where there's inflammation of the blood vessels. It can affect the lungs, the kidneys, and it requires immediate stopping of the drug and treatments. And, it's very serious. And this is the one side effect that can occur after years of treatment. It's much, much more common with propylthiouracil than it is with methimazole, but it has been reported with methimazole too. But I mean, there are case reports in the literature of this. That's how rare it is. I mean, it's just not something we really are concerned about. I mean, there's just a handful of instances that this has ever occurred in anybody taking methimazole. So I wouldn't worry about it.
Well, thank you so much. We weren't able to get to all of the questions. We got a lot of questions. We'll put our contact information up. If we didn't get to your question today, please feel free to reach out to you and we'll try to get you an answer. I will note that I'm seeing a lot of questions come through the Q&A about alternative therapies, specific supplements. And, unfortunately, we don't have any alternative therapies that are proven to be both safe and effective. And then in terms of supplements, we would advise you to talk to your endocrinologist about any supplements that you're thinking about starting. Some of them can be toxic in larger doses. Some can have interactions with other medications. So definitely let your own doctor know about all of the supplements that you're taking or thinking about taking. So thank you so much to our presenters for volunteering their time on a Saturday to share their expertise. Thank you to the County of San Diego for providing funding for this program.
Thank you.
Yeah, absolutely. And, also to all of the people who submitted excellent questions. This is this tends to be a pretty savvy community. So we got lots of wonderful questions. And again, if we didn't get to your question today, please do reach out to us. So stay safe and have a wonderful day. Thank you, everybody.